It is 8 o'clock. Good morning. I'm Shannon Switkowski. I'm the clinic coordinator of Cardi-OH ECHO. And we like to remind you to keep yourself on mute if you're not talking. If you're on the phone, you can use *6 to unmute yourself. If you have tech problems, there's a phone number here that you can call. Rick would be happy to help. We're going to go around the room here and introduce ourselves.
Thank you, Shannon. I'm Goutham Rao. I'm the director of Cardi-OH ECHO.
Yeah, hi, I'm Jackson Wright. I am a director of, or team lead for the team best practices of cardio and at Case Western Reserve University.
I'm Rick Carnaccio, the web content producer for Cardio.
Okay, thank you, everyone. Dr. Rao,
Okay,
start us off?
so we're going to start off here. The reminders, I think, are pretty standard, the same ones that we've had in previous sessions. This is kind of the basic structure that we'll be following this morning as well. We will have two presenters this morning. Included among them are both Drs. Taylor and Wright, and you can read their financial disclosures here as at your leisure. This, I think, is a really important session because so many of our prior sessions have focused upon pharmacological management. Larry Apple, who's been one of my mentors, has always said that salt restriction, when it's strictly enforced, which of course is difficult to do sometimes, can be as effective as another agent for hypertension, or if not more so. So if you've got someone with a single agent and you really want to control their blood pressure, salt restriction might be an alternative to adding a second agent. So with that introduction, we're going to turn things over to Dr. Wright, I think, to start with. Okay.
Thank you, Goutham. The objectives of this session this morning are shown here. Explain the role of salt intake in controlling blood pressure, the epidemiology of excessive intake across the American population. Will not deal much with that, but also, more importantly, describe strategies to promote reduced salt consumption among patients with hypertension. When I saw this slide, my first thought was that this was actually a garbage can, but unfortunately, it is not. In fact, but it does contribute to a significant amount of the hypertension that we see, and therefore its complications. And so, therefore, it becomes a major challenge in the management of patients with hypertension and in the production of hypertension in the U.S. When we talk about salt restriction, there is a suggestion that we're dealing with salt sensitivity. A couple words about salt sensitivity. One is it's a poorly described phenomenon. There's multiple ways of assessing salt sensitivity. However, the one thing you should note is that in carefully conducted studies with careful measurement of blood pressure, careful measurement of salt intake, and the appropriate analyses, about 70% of patients, normotensives, will show a significant increase in blood pressure with increased salt intake, and about 80% of hypertensives will, in fact, do so. Now, there are factors that are generally associated with increased response to salt. They are shown here on this slide. One is with increasing age, salt sensitivity or responsiveness to salt increases. Genetic factors can increase salt sensitivity. Individuals with hypertension, diabetes, chronic renal insufficiency, as well as obesity and low potassium intake are associated with increased salt sensitivity. Listed here is in African Americans as a factor. That is not because of the skin color, but is in fact because of this population is more likely to in fact have the associated factors that increase the likelihood of responsiveness to salt. The DASH diet, there's a lot of discussion about the DASH diet, and I was actually served on the Data Safety and Monitoring Board for this trial. It was a randomized feeding trial where patients were brought in and actually fed initially two diets, the DASH diet and control diet, but then the second part of that trial was to combine evaluate the effect of the DASH diet at 3 different sodium levels. And then with outcomes on blood pressure measured 1 month later. Compared the usual salt consumption similar to what is usually found in the American diet, about a little over 3 grams, intermediate about 2,400, but 2.4 grams, and then 1.5 grams of salt, which is the recommended salt intake currently. And the effect of the salt diet, this compares the higher versus the lower salt diet in both, here shown in both African Americans and non-African Americans compared to the control diet. And what you see is a significant reduction in blood pressure associated with the lower salt diet compared to the average, the normal control diet in control salt intake. And this effect was seen in both African Americans and non-African Americans, slightly more of a reduction in African Americans. Here, the effect of the same comparison, but now based on age, here above and below age 45. Again, older patients, generally with increasing age, there is a greater effect of salt restriction on on blood pressure, and in a greater effect on blood pressure reduction. Now, the DASH diet was actually a feeding study of salt intake, but before the DASH diet, there were a couple studies, notable studies looking at salt reduction, but this was done in patients who were counseled on salt restriction. In the trials of hypertension prevention, the question was asked, can sodium reduction and or a weight loss prevent the development of hypertension in overweight, in this case, pre-hypertensive adults? And so these were patients who were not treated for hypertension. And the question was, this looks, here are the data for the percent reduction in the development of incident hypertension, at that time defined as a blood pressure greater than 140 or greater than 90 at 36 and 48 months. And as shown here, there was at 6 months a fairly substantial in the yellow bar, both weight loss and salt restriction did reduce the incidence of hypertension by about 40% at 6 months, and even out to, I think the longest duration was about 30 months. And you still see significant reduction of about 20% in the incidence of hypertension with both weight loss and with salt restriction. The other question is, what about in older patients? There's a suggestion, or there was the feeling that patients with increasing age, patients get used to their dietary intake and are more reluctant to reduce salt. This was assessed in the TONE trial, treatment of hypertension in the elderly. And These are patients between age 60 and 80. And again, looking at both the reduction in blood pressure as well as change in urinary sodium. On this slide, what you see is that even in these patients over between 60 and 80 years of age, that this is salt restriction, and you can see change in urinary sodium was significantly reduced and was maintained for up to 30 months during in this study. So that, you can reduce sodium intake even in patients over age, even in older patients. And finally, question is, can salt restriction prevent cardiovascular events? Data is a lot softer. It's extremely difficult to maintain a sodium reduction or compare different levels of sodium intake in a trial and look at cardiovascular outcomes. What we have here is the data from the longer term follow-up in 3 studies. The TONE trial, which we described previously, there was at 2.5 years of follow-up after the trial had concluded, there was about a 21% reduction in cardiovascular events. There's a Taiwan veterans study. Again, this was with a decreased salt, increased potassium diet, a significant 41% reduction in cardiovascular mortality at 2.6 years. And in the treatment trial of hypertension prevention at 10 to 15 years out, there was a significant 30% reduction in cardiovascular events. These are the Kaplan-Meier curves for the trials of hypertension prevention. There was the first is the pilot study, and the second was the large scale trial. And as you can see, that this is after the trial had ended, was the lines began to separate, and as you can see, this is out to approximately 15 years. So this was long after the trial had ended. But bottom line is, I think, is that salt restriction is doable, even with counseling as well as with feeding studies, and even in older populations. It does reduce blood pressure, and we have suggestive evidence even that can prevent cardiovascular events. With that, I'll turn the
Just one question, Jackson.
Yeah.
These folks were able to restrict their salt for that many years, even after the trial ended?
This was do not have data on whether or not their dietary intake of salt continued. What the data is essentially, these are database follow-up.
That's amazing.
Yeah.
Yeah.
But I mean, this is certainly not definitive data, but certainly suggestive.
Thank you. Okay, we'll have a little time at the end for questions. Chris, you're up.
So we've talked about the DASH diet, what it is, and how it's been shown to be effective in actually reducing hypertension. But I think the key ingredient in all of these recommendations we have is it's great that if we create our evidence-based recommendations, but if people don't follow them, there was a big story that came out yesterday in The Onion. I don't know if anybody has seen it. Basically, they wrote about dietitians, said we've been telling people what to eat and telling people what to eat, and they don't do it. So go out and eat dirt and sticks, and you'll be healthier. So that was kind of a big tongue-in-cheek story that's been circulating around. But we can look at what the DASH diet recommends. So then what I did was take the national data that I used for dietary patterns, and I wanted to look at individuals that were 50 and older, and how much of each of these are these individuals consuming on this given day of intake. And looking at 6 to 8 whole grains per day, That's always one of our areas where we struggle the most. We're at 0.9 ounces of whole grain per a day when we're looking at 6 to 8. And across the board, we're under consuming the foods that we're promoting, and we're over consuming the foods that are contributing to our negative impacts. So salt becomes one piece within this broader element, and that'll be something we'll cover a little bit more in a later session. But also looking at where the salt comes from in the different foods around this wheel helps to kind of guide the types of recommendations that we might make. So much like when we get into weight management types of recommendations, sometimes the recommendations that we make give us somewhat the simplest answer to our questions that we're trying to achieve, as opposed to the most applicable answers. And so salt shakers become one of the kind of go-to elements within our sodium intakes, and then anything in a can and anything in a bag. And those do start to become some go-to messages that we can use and some kind of quick actionable strategies. But we also need to look for some of those bigger contributors overall so that we can really kind of understand what are the foods that we're eating, what are those big ticket items that are contributing to our overall sodium intake. Because if you can get somebody to stop using a salt shaker on their eggs, they're going to reduce their sodium by a few milligrams. But if we look at some of these larger kind of food sources, this is where we can get to big level changes in sodium, as opposed to some of the smaller elements that either we eat a little bit of, or things that may have higher sodium but just aren't consumed all that frequently. So I took the food intakes and broke those foods down into about 15 different food categories. And our top source of sodium within the diet comes from our mixed dishes kinds of foods. These are Asian dishes, Mexican dishes, pizza, Italian, sandwiches, those kinds of things. So that's where we're actually seeing the lion's share of our salt coming in. And then protein foods. Protein foods come in number 2, which are going to then get into our processed meats and those kinds. So those are where some of our actionable strategies that we talk about, foods that are high in sodium, do start to pan out into some of the larger pieces. So I'm going to throw out a question really quick before I progress. When we looked at the individual foods that are contributing to sodium intake, what single food is contributing the most to older adults' sodium intake? Anybody have a guess for me?
Potato chips.
Got a potato chips. Anything else?
I'm not going to cheat.
You're not going to cheat. It's pancakes, bacon, frozen meals, white bread. White bread is our single highest contribution of sodium for a single food. Not because it has a lot of sodium in it, but because we eat a lot of white bread. Compared to everything else that we eat, the combination of white bread with a little bit and having 6 to 8 servings of those across the population level actually then translates in. So that's why it becomes really important for us to kind of look at what foods are contributing and which ones are they consuming, rather than maybe falling on some of our individual elements. Mixed dishes, we can see between the things that are added in. We typically don't always add vegetables. We tend to add other things like meat and cheese and soups and things like that. So it creates an opportunity for us, if we're going to be looking at some of those, to then talk about what are those mixed dishes they're eating? How can they make those things a little better? That's kind of our first strategy. So let's go on to the next slide. So to break these down, back one. So to break these down just a little bit more, I can take these down into more discrete categories than those first 15 groups. And our chips and bakery products and those kinds of things start to show up a little bit more. But then you can really start to see here soups are starting to play a role in our higher sources of sodium. But this kind of gives us an idea of how many of these things are ones that we typically look for and ask about when we're asking about, as opposed to chips and soups and those kinds of things. So it gives us an opportunity to kind of think a little bit broader about where the sodium is coming from, because if we can address those heavier hitters, then we're better able to make smarter choices, which the food labels will allow us to do, and be able to have some of those larger impacts on sodium intake, rather than maybe smaller strategies of if we reduce chip intake, that might help us at one of our snacking occasions, but we're still looking at the rest of the day and how it contributes. And this is also another one of those areas where the consumers have to fight multiple sources of information. We have the food label, which is being revised. It's been delayed, but it's supposed to come out and give us a much better idea of what really is a serving size. So one of the updates that they've been making is that the serving size, this 2.5, is how much are people actually eating to represent a serving, more so than how can we partition the can out to make it look better, kind of scenario. So with this soup, you add it in, add the water based on the directions. It's supposed to give 2.5 1/2 cup servings of soup to be a normal serving size. Within that, 410 milligrams of sodium. So 2.5 servings. I don't know a whole lot of people that don't eat the whole can. We're looking at basically 1,000 milligrams of sodium from a product that is essentially labeled heart healthy. So heart healthy is being labeled based on other elements of cardiovascular health, and I can leave it to the group to determine if 1,000 milligrams of sodium is considered to be heart healthy for hypertension. So looking at the products themselves and getting past the labels that say it's good for your heart and it's good for your whatever, those have a tendency to be USDA-based arguments for not particularly the elements that we're looking for, especially heart health, cardiovascular disease, hypertension. So being able to evaluate this food label and looking for the hidden sodium that's really in these products is going to be one of those elements that'll be very valuable for patients themselves. So we do have several strategies that we can look at for reducing sodium. And the more processed foods are, the more likely we are to provide additives to make them last longer. So we need to look at the types of foods that are being consumed. If we're looking at more highly processed foods, canned foods, things like that, we need to be much more aware of what's on the label, like we just saw in this soup example. But we also have to be sensitive to the fact that we're looking at that mapped out version of the DASH diet, and we're promoting individuals to consume fruits and vegetables. And when we're focused on social determinants of health, the capacity for fresh or frozen fruits and vegetables starts to create a conflict. Don't eat canned things, but we want you to eat vegetables. So looking for opportunities in these, especially if we have to go with certain processed foods, to look at the sodium content and to be able to make informed decisions. You can get corn that is canned with salt. You can get corn that is canned with sea salt, which supposedly sounds better, but they may not realize it's actually salt. Or you can see it with sodium, low sodium. Those typically don't cost more. And if they're not available, they can empty the can, rinse off the vegetables again, with water after they've drained them, and that will help to significantly reduce the amount of sodium that's in there. And then also looking for these sneaky sources of sodium within our diet. The mixed dishes, as we start to add things like cheese and soups and meats and other things to our dishes, we're kind of slowly adding sodium into foods that we're not kind of commonly focused on how those play out. And in reality, mixed dishes make up about 40% of the calories we eat in a day. So the contributions that mixed dishes make overall have a very strong influence on our daily intake. So the changes that we can make there can have broader implications. And then this really kind of, the flavor profiles and sensory thresholds really kind of start getting towards the question that Dr. Rao had asked about how long were they able to prolong these behaviors, and were they able to keep these going. The longer that you continue, I believe it's about 3 to 4 weeks before your taste buds kind of start to make the transition to these new flavor profiles. Using seasonings instead of salts, herbs and spices can allow you to get some of those same flavor profiles without adding the sodium. But it takes a little time for your taste buds to adjust to this. But once you make that adjustment, as soon as you taste something with a higher salt threshold, you become much more sensitive to those. So once you can get past that initial stage of weaning yourself off of these higher sodium foods, you kind of develop less of a tolerance for them, and you become more sensitive to their flavors. So it does make it a little easier to prolong. And then finally, I thought it would be important to consider the fact that the implications of what fat diets play into these foods and what it ultimately means. So the ketogenic diet basically is a low carb option, which then makes you much more reliant on protein food sources, which typically those protein food sources are then going to be a carrier of sodium, lots of other processed foods. The same thing with gluten-free. There'll be other manufacturing type processes that need to then make the product shelf stable. So that will then contribute another opportunity for sodium. So thinking about if they start making this broader change, keto, low carb, gluten-free, whatever the diet du jour is, as they continue to focus on that one key element that may be weight loss is not in itself the sole health outcome, because it'll have potential lingering effects afterwards. So various resources that do exist, as I'm sure we all know, the DASH diet has numerous iterations and resources that are available online in book form. I have some colleagues that have written some various books around implementing the DASH diet. I know there are a wealth of resources out for that. The American Heart Association and the NHLBI have also invested a significant amount in developing translational tools to take those dietary practices and help translate those into meal plans and actionable strategies for lifestyle behavior. And then as well, I know that these then become very complicated storylines. So the Academy of Nutrition and Dietetics does actually have a Find an RD tool that both clinicians as well as consumers can go in and search their area and find a dietitian who we fill out our profiles based on what type of expertise we have in the target populations. And it becomes another way of when you have that struggle, when you don't have your own dietitian or referral, being able to utilize that as a strategy to find that next step assistance when kind of the simple guidance isn't going to be enough. And from that, I will turn it back to the hub.
Thank you, Chris. Great presentation. Let me throw out a comment. And I think that I understand that the spectrum of salt consumption across the diet kind of implicates mixed dishes and staple foods. But I'm wondering about our subpopulation of hypertensive patients. And I was in clinic just yesterday, and I had lots of African-American men, not terribly old, not in their 60s or 70s, but in their 30s and 40s and 50s, who were hypertensive. And my impression is, and I don't have any epidemiological data, is that the consumption of especially salty foods contributes more across their diet than it does in other groups, like the more, the older adults, the intact family, other ethnic groups. They are relying a lot on convenience foods because that's part of their lifestyle. Potato chips, fast food, etc. So I can recommend, hey, the big salt sources in your diet may be mixed dishes. Maybe that's true, but you eat a lot more potato chips than you probably should. And if you just got rid of those or switched to a low salt alternative, that might have more of an effect on your blood pressure than it would on your 85-year-old mother, who I'm also seeing today, for example. What do you think about that approach?
Yeah, and I think that's where it gets down to the individualistic consumption patterns. What you do kind of get out of that bias, I was trying to also kind of match some of the data that we had from the previous part as to going with the 50 and older. But the younger that we see the patient, the poorer their overall diet quality and the kind of the different patterns. We've had several papers we've been working on recently where basically, if you want to be healthy, you got to eat like the 70 and older because they're actually cooking for themselves.
Yeah.
As you get back to the 50-year-olds, they're the individuals that we say, I'm sure you're working and I'm sure you're fine because you seem to be healthy, but you don't have any health problems. So we'll just let you keep going until something develops. They have a significantly poorer diet quality and are starting to reflect the types of behaviors that you're talking about. More convenience foods, more fast foods, in that element. And then as you go younger, the patient you're describing starts to continue to shift back towards more of those behaviors. And that's where you kind of look at the big piece of, and I've mentioned this before on our echoes, if you have a fast food meal with an extra large bacon cheeseburger and a large fry and a soda, which is the bad part? And which one element do you identify? The large burger becomes the mixed dish in this situation is probably the lion's share of the calories and the sodium, and then you add the fries with sea salt, and then they have chips after that. So getting down to those core elements of if they're eating more fast food, what are they eating? How do those pieces get us there? That allow us to drill down to, are they consuming those, which is what you're getting, as opposed to kind of starting with the chips and then using that as the strategy. So you're coming from the bottom up approach of what they're eating from your discussions, as opposed to starting top down to say, we need to focus on chips. Do you eat them? Kind of scenario.
Makes sense. The other thing I would say is that public policy plays a big role. I mean, very few people know that cornflakes have about 17 to 20% less sugar now than they did about 10 years ago. And the reason is every single year, the amount of sugar is reduced just a slight amount. And this is not salt, obviously. So I do serve on the science board for the Dannon Yogurt Company. And the chief scientist will say, you can lower the sugar to a specific threshold below which kids won't eat it anymore. You can stay above that and they'll kind of not notice so much. I'm wondering, Chris, is that also true with salt, that there's a certain taste threshold that if you fall below it, the dish becomes unpalatable to people?
Yeah. Now I don't have the food science aspect, and I have a colleague that I rely on that, but we do collaborate on a handful of projects. Interestingly, one of the projects that we had done was looking at the transition in cookies in the marketplace after the trans fat push. Trans fat, it's bad for heart disease. We need to remove it. So food companies were basically trying to find a way to create the same products without trans fat, to get the same flavor, to get the same composition and not crumble and things like that, which essentially meant take out trans fat. It meant add sugar, add salt, add calories, and add saturated fat. which are all bad for heart disease. So we do have a push to make a lot of changes in our food supply. But when we do that, we also have to think about what the implications of those other changes are. But we also can look for pushes in sodium reduction in our food and find alternate ways to improve preservation. But unless there's consumer push for that, to then work with policy to make those changes, we'll continue to see that higher sodium content process.
Jack?
Yeah, the British have done a great job of in terms of reducing salt as part of public policy, and they've been reducing it. I guess Graham McGregor began those discussions, I guess, about 10 years ago, and they've now begun to see a reduction in even stroke rates within Britain. The other is I've done a number of salt sensitivity studies where we actually provide foods for patients at 10 milliequivalents versus the usual diet. And it's what's been amazing is the fact that if you put a patient on a 10 milliequivalent very low salt diet for just a period of a week, and then return them to the usual salt diet, and in crossover studies, the dissatisfaction with changing from a high salt diet to a low salt diet versus a low salt diet to a high salt diet, the patients distinguish, and the dissatisfaction is fairly similar.
Yeah.
And so the taste for salt is in fact acquired. And using that, I've actually had success in reducing salt intake in many of our patients, or at least some of our patients with hypertension, as measured by 24-hour urine sodiums.
Good, great comment. And if you've ever bought a bag of chips now in Britain, like you're passing through Heathrow Airport, and bring it home and compare it to one of our bags of chips, there's a noticeable difference. Mm-hmm. There's some comments about sugar. I can talk a lot about sugar and go on and on and on about it. So yes, so people don't notice sugar if it's gradual. Sugar sweetened beverage consumption is affected by taxation as long as 3 criteria are met. The tax is sufficiently high. Of course, it has to be applied to a broad range of sugar sweetened beverages, not just soda. And finally, the money that's raised should be used for health promotion rather than plugging gaps in state budgets. And if you Google my name, you'll see some YouTube videos from Illinois and other states that relate to that. Final thing before we move to our cases, does sea salt or regular salt make a difference? Sea salt doesn't have iodine. Chris, I think you'd agree, it doesn't make a lot of difference in terms of hypertension and health.
Okay. Sea salt is trendy, but is still salt. And the same thing with I saw the comment on the Impossible Burger. The primary function of the Impossible Burger was to create a meat not based on meat. So ultimately it's a processed food that then is going to contain that. So the health halo, as I mentioned with the heart healthy products and things like that, the health halo that comes with these types of food trends that come along don't necessarily make them healthier choices. When the low fat phase craze happened, everything was low fat, but sugar was what replaced it. So all these changes are Newtonian is what we have to think about. Every time they change something, something else happens. So we need to understand what that something else is. And in the food supply, we need to guide what that something else is. Otherwise, we're going to have other complications.
Thank you. I just there's a comment from Jim about the research on mixed dishes being high in sodium. Are these usually processed foods? Yes, I would expect that the sodium would be much lower in mixed dishes made at home. Chris, do you want to just comment on that quickly?
They can be if they're made that way. I think that gets to another one of those elements, and we could go on for these forever, clearly. But cooking at home means where the food was prepared. The cooking strategy used cooking at home becomes the more important element, because you can cook convenience foods at home. So depending on how much people make foods from scratch, which becomes far fewer and fewer, the more we use convenience foods and other elements that then help us build that.
Yeah, it's 13 minutes a week now that the average American family prepares food from scratch. A week, not per day. So that's pretty low. So let's move on to our cases. Great discussion. And we will have Angel Williams, I believe, is the first case. Interesting case. And as I was implying in my earlier comments, I think I saw like 3 or 4 of these guys just yesterday. All of whom were working, all of whom were 30, 40, 50 years old, all of whom had girlfriends, had the same, who were nagging them to do something about their blood pressure. And some of whom came in with their mothers whose blood pressure was perfect. And so this is a really interesting problem. I'm very skeptical he's taking all of those medications. There's like 2 different nitrates on there. Maybe I start with maybe Jim, if you had any comments about how to find some motivation in this guy who is a city worker, who cares about some things a great deal, I'm sure, but his adherence has been really subpar so far.
Sure. Great job by the clinician in taking care of this complex patient. How important it is for him to take care of his health versus the priority he places on his job. And one pretty simple way to assess that would be to just ask a scaling question, a scale of 0 to 10, how important is it for you to control your blood pressure? And then when he responds, why is it that you chose, say, a 6? And then you can understand his understanding, essentially, of what the risks are, what his values are, and why this is somewhat important to him, but not as important as probably should be. And then the next question would be, what would it take to be 1 point higher on that scale, a 7? And that would get at some kind of perhaps a task or a better understanding for you of where he's at with respect to making this a priority. The other thing is it's possible that he has low confidence in his ability to take these medications because he's on a complex regimen. And it's possible, although I think it's probably more on the priority side, the importance side, but it's possible that his confidence is just very low in being able to implement this regimen. And so he's just kind of essentially throwing in the towel and saying, well, I'm going to set that aside because it's so complicated and focus on my whatever other aspects of my health. So those are a couple ideas. Another one, if you really can't sort it out, is just to do a values list with him and ask him to just identify what's most important in his life and talk about that with him. And those things are readily available online. So those are my comments.
Thank you, Jim. Those are good comments, and that's an interesting strategy. Strategy that I have tried in terms of compliance, and of course it may or may not work, and I don't have any actual evidence for its efficacy. So if you ask people, is there something that you do every single day? And usually, that's not everybody, of course, most people across all age groups, ethnicities, kids, adults, brush their teeth every single morning. There are people that do not, but it's pretty universal. And I'm guessing this guy probably does the same thing. And you could say, well, if you brush your teeth every morning, you've got to go through a few actions. You've got to get your toothpaste, your toothbrush, and you've got to put it on there. When you do that, I want you simultaneously to take your whatever amlodipine and let's say a couple of them, spironolactone and your ACE inhibitor or ARB, I don't know, valsartan. And that way, at least, that you've got something that holds you a little bit accountable and there's an action. You keep those bottles next to that. Or you do that on your way to work because you drive to work every day. Something that allows him to take his medicines on a regular basis. Now, convincing him that these medicines should be taken on a routine basis rather than PRN, I think is going to be tough as well. So a couple of comments. Jackson, what do you think of his regimen and how would we improve it?
I think the regimen TID medications, I think, are certainly problematic. The other is and so that I'm actually impressed. He does have heart failure, even though his ejection fraction is in the 50s. But with the heart failure, he is on the. Many Black patients are actually not on the nitrate and hydralazine regimen, and so that's impressive. In addition to the beta blocker and the ARB, but the hydralazine is TID. May be able to get by with making that BID, the gabapentin TID. You'll probably take PRN, but probably get at least at midday hydralazine. One other feature is that you mentioned he does have significant edema. You also mentioned that his blood pressure was not controlled on 25 of hydrochlorothiazide in the max side. One way to, and he does have significant edema. One method may in fact be to switch him to either furosemide at 80 milligrams. That's about equivalent to hydrochlorothiazide 50, which is chlorthalidone 25. So you could actually switch him to get better blood pressure reduction with a thiazide, and then use the furosemide to treat the edema. Now you'll use much lower doses. You would start out with 10 and then titrate up to 20, because the combination of the thiazide plus the furosemide can be a very potent diuretic. So it may get away with get around some of the edema. And lastly, it also may allow you to reduce the amlodipine. My bet is that he is on hydralazine plus amlodipine, and that some of his edema may in fact not be the pedal edema from volume overload, but in fact may be because of the arteriolar vasodilatation. So bottom line is consider getting rid of the TID dosing. That way you'll be able to use 2 triggers during the day to take the medications: breakfast, brushing your teeth, bedtime, or supper for the PM dosing. Reduce the amlodipine and replace the furosemide 80 with the thiazide, and then supplement with furosemide to deal with the edema.
Thank you, Jackson. The one other comment I make, I think Angel had mentioned this, and that is I would recommend home blood pressure monitoring for this gentleman to raise his awareness of what the condition is. And in my experience, people who do monitor their blood pressure have an awareness